We looked at the mechanism of action of antiretroviral agents and what DHHS guideline recommends for treatment of HIV patients. We ensured adherence to ART is optimized and designed an individualized monitoring plan. Now, given a prescription for antiretroviral agents, provide patient counseling for adverse effects.
So you can see that these are the drugs that are most commonly used. This is not a complete list, but these are the most commonly used. So you should definitely know all of these. So it's important to know which one needs to be. So if it says no for food, that means you can take it with or without food. But in a particular, elvitegravir needs to be taken with food. So is rilpivirine. So anything that has rilpivirine, and Juluca was also recently FDA approved. Note that Juluca is a little different, and it's not in the guideline yet. So you should. The only thing you need to know about it is that it doesn't have a backbone. So this is an exception to the rule that you need two nukes plus a third agent. So they eliminated the nukes as the backbone, and instead they're using two highly potent drugs together. But it's not in the guidelines yet. And per FDA approved package insert, you can only start it in someone who's already been treated for HIV and the viral load is suppressed for at least 6 months. And then you can so if the backbone is causing problems, so more specifically, if someone is on tenofovir and they have nephrotoxicity and bone toxicity, then you can actually switch those patients to dolutegravir rilpivirine because it doesn't have the backbone, so you won't have some of that toxicity. So we'll see how the guidelines will actually recommend these once the new one comes. But regardless, because there's rilpivirine here, you have to take it with food. And then with Complera and Odefsey, there's rilpivirine, so you need to take it with food because rilpivirine needs an acidic environment to be absorbed. So eating with food helps release the acid, so it helps with absorption. Now with efavirenz, it's the other way around. You actually want empty stomach because of severe adverse effects of efavirenz. We actually do not want it to be absorbed as much. So what they said is, with ATRIPLA, take it on empty. It has to be on empty stomach because if they eat food, you're gonna get too much toxicity. In fact, this was so important that they actually came up with a new formulation called Symphilo. So the low means the efavirenz is actually a lower dose, and they still want you to take it on empty stomach. Okay, so because of those adverse effects. So Symphilo is actually pretty new. It was FDA approved last week. And then so for the rest of them, when it says no, it doesn't matter. You can take it with or without food. And with protease inhibitors in general, you need to take it with food. So whether it's darunavir or atazanavir, you need to take it with food. Now let's take a look at some of our nukes or NRTIs. So NRTIs are nucleotide reverse transcriptase inhibitors. So nukes, so lamivudine and abacavir. So generally speaking, as an entire class of nukes, because they're nucleotide analogs, what they can actually cause mitochondrial toxicity. And the reason is inside the mitochondrial in the host cell, there are polymerases in the mitochondrial that actually uses nucleotides to replicate mitochondrial DNA. And because these are analogs of nucleotides, that DNA polymerase can actually be inhibited by these nucleotide analogs. So especially older nukes cause severe mitochondrial toxicity leading to lactic acidosis. So you will see lactic acidosis as a black box warning for pretty much all of the nukes, but note that these are primarily from the old nukes that we don't really use anymore. So the current, four newer nukes that we actually use, they have less affinity for DNA polymerase, so you don't see those side effects as much. But it's still important to be aware of it just in case, because not all patients are equal. So occasionally you will see a patient that is most likely to have these adverse effects. And of course, with abacavir, you have to check for HLA-B5701 allele polymorphism. And if the patient is positive, you should not start it because they will be at, you know, there will be at least a 50% chance of having a severe and possibly fatal hypersensitivity reaction. Another problem that was with abacavir, around a decade ago, was that there was talks about increased risk of myocardial infarction with abacavir, and this all was mostly from observational studies. And the problem with observational studies is that they are at high risk for bias. So that's why you will see a lot of the drugs actually using the backbone of emtricitabine and tenofovir, and that was because a lot of people were reluctant to use abacavir because of the increased risk of MI. So the FDA actually reviewed 26 randomized clinical trials, and they did a meta-analysis, and they actually said that no, abacavir does not increase MI. So if a patient hears about the risk of MI, you should let them know that FDA has done a meta-analysis and they have not found an increased risk for MI, so it's safe to use. Tenofovir, as I mentioned, so nephrotoxicity and osteotoxicity are the two top adverse effects of tenofovir, which is higher with disoproxil fumarate because of the higher dose, and it's less likely to happen with TAF. Zidovudine is one of those older nukes that can actually cause mitochondrial toxicity. The reason we still have zidovudine on the market and we use it because it's actually available as IV, and because it's pretty old, we've had this since the 1980s. There's good data in pregnancy and during delivery. So this is one of the IV infusions that we actually do when someone is giving birth to a baby who has HIV. So that for that reason, zidovudine is still on the market and we still use it. So with elbitergovir, which needs to be boosted with a pharmacokinetic booster, cobicistat, and of course this uses the backbone of tenofovir. So tenofovir causes nephrotoxicity, but one thing in particular that cobicistat does, it can actually cause a small increase of serum creatinine. And this is, although it increases the number, cobicistat does not cause nephrotoxicity. It actually blocks one of the channels in the kidney that actually normally secretes serum creatinine. So it actually blocks the secretion of serum creatinine in the kidney, and because of that, the number artificially goes up. But it really does. Cobicistat alone does not cause nephrotoxicity. And of course, bictegravir, which was approved last week, is a second generation integrase inhibitor. One thing that's great about the second generation integrase inhibitors is that they're well tolerated, they have a high barrier to resistance, and they don't need the pharmacokinetic booster. Triumeg, which is the only combination regimen that actually uses abacavir and lamivudine as a backbone, is also second generation integrase inhibitor. It also comes alone if somebody, if someone had HLA-B5701 positive, you cannot use Triumeg. So it comes as TVK alone, so that you can use a backbone of tenofovir and emtricitabine like Truvada, for example. So you will have to give them 2 pills. Raltegravir is a first generation integrase inhibitor. So if you use the 400 milligram, it has to be dosed twice a day. If you do the 1200 milligram, then you can do the once a day dosing. Now the 2 protease inhibitors that we use are darunavir and atazanavir. So darunavir um, should be taken with food, and it also needs to be boosted. In fact, pretty much all of the protease inhibitors need to be boosted. And here's non-nuc, so NNRTI or non-nucleotide reverse transcriptase inhibitor, rilpivirine. As I mentioned earlier, you should only use this if the patient's CD4 count is greater than 200 and their viral load is less than 100,000. Don't worry about these groups. One good thing about the non-nukes is that they do not inhibit the mitochondrial polymerase, so you should not have those mitochondrial related toxicities. And then the other non-nuke that we use is efavirenz. One thing about efavirenz is that it actually increases the risk of depression, suicidality, and that's actually the primary reason that it's an alternative because of the risk of suicide. The other thing is that it can actually, because it primarily causes CNS toxicity. So whether it's depression or suicide, it's CNS toxicity. But another thing that it can actually do, it can cause vivid nightmares, so vivid dreams. So for that reason, it's recommended to take it at night because by the time it's actually absorbed and the side effects kick in, the patient wakes up in the morning, so the vivid dreams, which becomes a real problem. It will be one way of dealing with it. And of course, a lot of these CNS effects will resolve after two to 4 weeks. So if it's within 2 weeks and someone's complaining, you may continue for 4 weeks. But if they're still complaining beyond 4 weeks, then you may want to switch to something else.